between 2010-11, and there was interferon, which seemed to suggest that there was very good response. And but one of the questions which was always there is, what are the lesions that are most suited rather for sort of treatment with either interferon or MMC 5FU, whichever drug you choose. Now, one of the things that was predominantly there in the literature is if you could find out that what is intraepithelial and what is invasive, then you sort of take your surgical interventions to the invasive cases, and you do all sorts of intervention with immune therapy and chemotherapy to the intraepithelial lesions. With that in the background, I remember I was at ARVO, and there was a lot of studies on possibility of trying to use OCT in multiple, and that struck me that let's use OCT to see whether we can differentiate that, and that's the actually background to what we started out to do. One particular case where around this time we also had a time domain Visante Zeiss anter-segment OCT with us, and this particular lady was who was a 65-year-old female. She had, as you can see, a limbal lesion. What was very surprising was that this limbal lesion, it's like a spotter. Anybody would think this is OSSN. But the moment you everted the eyelid, you had this picture on the upper tarsal conjunctiva. Now, that's again bizarre. So it's actually two lesions, and there is no contiguous, contiguity between them. But having said that, whether there was cells which was obviously, this was in close proximity with the upper tarsal conjunctiva. So there's most likely there was cells from one, whichever was and we would think that probably the limbal lesion was the one which was the primary lesion. There was no regional lymphadenopathy. Now this particular lady, we subjected to anter-segment OCT. So what do we get? Now, based on what we had, we looked at what the literature was talking about changes that are there in anter-segment OCT. So there were several things talked about. There was what was called as a epithelial thickening, and I'll try to use this. You can see it. So you see that there is an epithelial thickening. So that means what is epithelial? Let's go from this side. So there is epithelium, and then becomes thickened. And then you have an abrupt transition, which I've shown as an arrow, white arrow there. You have a hyperreflectivity, and you can see the difference in the, no, I'm okay. You seem to see that there is a hyperreflectivity compared to the other regions. You had a basal membrane. So then these three were described in the literature. We thought that if we are trying to see define some more, and we had this audacious goal that can we use ASOCT to differentiate between intraepithelial versus invasive malignancies. So we defined three new. One was the clear plane is there. Number two is a basal membrane that is present, that you see as the yellow arrowhead, more seen in this particular picture. That's where the scan has been taken, is shown as a dotted line there. And sometimes we had a significant degree of backshadowing, and that was particularly seen if it was a thick lesion or it was also, there was a leukoplakic lesion. So so once you've done your ASOCT, how do you ascertain what is the gold standard? Now we thought that we'll do histopathology. And in this particular lesion, of course, we could only get the histopathology of the limbal lesion, but we found that there seems to be some sort of an understanding that maybe it's worth doing as a prospective study, and that led us to this particular study, which we tried to take patients prospectively and use the time domain ASOCT. That's what we had with the histopathology, which was the gold standard. And the idea was we could differentiate carcinoma in situ from invasive. That was the thing that we were going out to try and find, and also evaluate the role, whether there was a role, it's at least in surveillance, because when you're using immunotherapy, a lot of times you don't know when to stop, because there were reports which said that it's disappeared clinically, but you still have to continue therapy. So what was the point? How do you know? So was it useful in surveillance? These were the objectives that we set out. Of course, we had consecutive clinically diagnosed OSSN cases. And what was the control at that point of time? We thought, well, pterygium patients could definitely be, and it was ethics approved, and it actually ran between 2014 to 16. So that's the background. And we had in the OSSN group 21 patients. In the pterygium group, we had 10 patients. You've seen the age and the follow-up that we had for both groups. I'll run through a few. This is the first case. Now, this particular this was the lesion that you see on there, and that's where the scan has been taken. This is what it shows, and whatever characteristics I talk about, they have been lined up here, and whichever we thought was present, we have actually named them. So there was abrupt transition, hyperreflectivity was epithelial, there was a clear plane that was present as shown here, but then there was no basal membrane, backshadowing was absent, and the histopathology. Now the big thing there was, how do you make sure that the place at which you are doing the optical section matches with the point at which you are doing the histopathology section? And that was quite a bit. At that point of time, there was small little, I would say, difficulty. And we found a solution to that by actually, Ruchi was a pathologist with us at that time. We actually used India ink. So we would actually try to mark it. And India ink is something that is also seen on pathology. So they can usually make out that that's the point where you've taken it. But if you really ask me, it actually smudges. So whether you are able to take exactly that line or not, it's really challenging. But you can possibly say that that's the point. And if most of the time she was finding that ink on the slide also. So, but it's still very difficult to make sure that you're exactly at the same point. So that's one of the fallacies of the study. Now this one we compare with a pterygium, and you can see it's quite characteristic. Look at this lesion, that's where the scan is running. And here, this epithelium looks absolutely fine, right? Compared to what you see there, right? And then that's the histopathology to confirm what you're looking at. Second case is something that we had, and this was, there's keratin, that's the lesion, feeder vessels, that's where the scan is running. That's what it shows. So seem to have at least all of these. They had a clear plane, and there was a basal membrane that was also present, right? So we started thinking that if the basal membrane is present, does it suggest that it's actually intraepithelial? That's something that's... Now this one came out to be severe dysplasia, but there was one site of focal invasion. Now question is, based on one of the limitations of the study, that where we were able to actually make sure the histopathology was coming exactly at the same section, but at least seemed to be like there's some correlation that possibly in intraepithelial lesions you are getting the basal membrane and the plane much clearer, is what we thought. That's what is actually tending to show the point. And there was one spot where there was a focal invasion, and that you can see there, right? So now we had a series of patients, as you can see, and I think I'll go to case 3 here. Now here, look at the challenge. The lesion was something which was quite uncharacteristic that way. And there, you don't really make out. That means you have the abrupt transition happening, you have the thickening, but the clear plane is absent, right? This one, however, turned out on histopathology to be actinic keratosis, right? So then it was not really differentiating from the precancerous lesions to lesions that were obviously intraepithelial malignancy. And that's the histopathology to mark what we had. So a series on, and like I said, we had about 21 patients, and I think the characteristics are there, and this is the particular case I was talking about, which was a multifocal OSSN, bulbar and eyelid lesion that I talked about. Case 4, this is very typical and actually goes, absolutely follows all of the characteristics we talked about. Right, has got the abrupt transition, has got the epithelial thing, hyperreflectivity is there, clear plane, basal membrane, all of them. This came out as mild dysplasia. Case 5 was a very large lesion. Now, this one, the challenge was the depth. There was huge amount of back shadowing, and we didn't really get much of a resolution in the depth of the lesion. Another thing that we found was also this, which is marked with a star there. And we thought, was it actually suggestive of actually an invasive? But was not so much, because actually this was invasive SCC. But Ruchi's thing was, when you have the epithelium and you're taking sections on histopathology, you actually have these, what do you call it, as pouches. And when you take that section, it doesn't necessarily mean that it is actually suggestive of invasive. So based on what we had on the gold standard, this really didn't come out as something as suggestive of an invasive lesion. But we found this in large lesions when we were doing this. This was again very large elevated lesion, and you can see these pockets of hyporeflectivity that we found there. And this was again invasive. So one of the things was, of course, that if the thickness of the lesion was large, right, it was quite high, then but that was not something which ASOCT had to tell you. I mean, you could also clinically look at the lesion and look at the thickness, and that could suggest. But of course, these findings that were not there, the problem was, because there is a huge amount of backshadowing, whether it is actually not there actually, or whether your reach up of the optical section is not allowing you to see that, was always a thing that we had in mind. Again, a set of the same patients that I've highlighted to show that. Possibly this is case 6, which had this keratin plaque here. And one of the things that you had there, we realized that had a significant amount of shadow at the back, which made it very difficult. So keratin lesions, or a lot of keratin and leukoplakic lesions, were not the right ones to actually look at, do ASOCT. Now I'll actually try to show the relevance of the same in surveillance. Now, this particular young chap was actually a 43-year-old immunocompetent individual who had a limbal lesion, and that involved 6 clock hours. He refused primary surgery and underwent immunotherapy. Okay, and that's he had no regional lymphadenopathy. Now I'll show a serial ASOCT that is done. Now there are 2 points at which it is done, and in the picture above you can see where exactly it is done. That's one at the bottom, and then at 2 places it is done. And whichever is done, that's shown in the ASOCT picture there. That's after some time, the change. Now, if you can notice very carefully, the lesion involves all these areas in this one. But when you start, this one is there, but you see some sort of a change here. This is after interferon. Okay. Now, this was a combination of subconjunctival and topical interferon. This is the same individual. Now, that's what I said. There is probably a relevance in immune surveillance. So while this starts looking like from where we were much better, but on the ASOCT, there seems to be, at least in the nasal, there's still some thickening that is there, and possibly would help you decide that you need to still continue on immunotherapy. Okay, so what did it actually tell us? Well, there seemed to be a good correlation between dysplasia and intraepithelial lesions. But, and we thought that, at least, like I said, the hyperreflective basal layer had some sort of a correlation, even in the small numbers that we showed, between CIN, which is carcinoma in situ, and severe dysplasia. We could definitely help differentiate it from non-malignant lesions, and but differentiating what we set out to do as the primary objective between intraepithelial and invasive didn't look like something that you could do, at least with the time domain ASOCT that we had. And there was definitely some role in immune surveillance, because when you treat them, you tend to know what is the change that is happening, and it helps you treat patients over a period of time. So that's about the ASOCT and its relevance. If there are any questions, I would be happy to take that. I've just got a few more slides on some atypical lesions, but they are different. So any questions?
So this is since cannot be one-sided. Will you go ahead and ask and then
So would you show that slide where there is the asociative one, where there is the clear plane and the basal margin? The previous one where there was a simpler one.
I'll go to the one
Huh.
which, yeah,
Yes, sir. Would you just tell once more?
okay. So let me just run through. Right. So this was the lesion, right? And we, like I said, these were the three characteristics that were already there, and these were the three characteristics we added to the when we set out. So what we're looking at, the epithelial thickening. So you can see that's the epithelium, okay? And that's get thickened. That's the layer which is getting thickened, right? Number two, it is hyperreflective compared to other regions, correct? Third is you have an abrupt transition, right? What we looked at is clear plane. Now you see between this layer, okay, and the other structures below, you had a basal membrane that was there. The arrow that is showing. No. And there was also a clear plane of separation between the two. Now you could say that both of them essentially mean the same.
So, sir, a clear plane is present though.
Yeah, so here we actually, sometimes we could always say that in different parts of the lesion, you could have a clear separation between this and the underlying tissue, right? But sometimes it is not there.
So if
But
it's
whenever
there,
there was so this basal membrane is something that we found had a reasonable correlation with the fact that if that was a intraepithelial lesion. That's what we found. This was, of course, something that was there, which was predominantly in thicker lesions. Let me go to another lesion which was. Now this one we thought that while the basal membrane was there, the clear plane of separation was not there between the two. Okay, came out as actinic keratosis. Now look at that. Now this is what we see is that there's a clear plane between the two and a basal membrane is also present. And this came out as an intraepithelial lesion.
so sir, for these cases, we can go for immunotherapy.
So if you extrapolate this, that based on this, did it actually help make a decision that that you can do immunotherapy? My answer today would be probably no.
Okay.
The reason is, while it gives you an optical section, the challenge is that there may be a large lesion and it may be intraepithelial everywhere that you tend to do the optical section. But may still have a couple of places where there is a focal invasion which you will not pick up. But by and large, you can get an idea, right? So that is there. We so extrapolating to the clinic, what exactly how does it help? We realized that if the lesion was something that was not very large, was not very elevated, on the asociety had characteristics like these, we could definitely think of first reducing with immunotherapy. That was something that we could take to the clinic. But whether we could confidently say that this particular lesion has no invasive is probably not the right thing to say.
So after reduction, we can go for surgery.
So with reduction, we know the two things, of course, apart from the clinical resolution that you see, it also helps you to know how long can you continue the therapy. That, like I said, that part was definitely helpful. And the second thing was sometimes the first lesion that I showed actually needed a surgery. It was actually the one which I showed with serial pictures. Let me go to that one. That actually needed a surgery because despite what all therapy, this particular patient, now he was a young individual, and even the lesion and the picture that you see at the bottom, that did not change. On the picture that you see at the bottom, that did not change despite all the therapy that went. This remained like that. So actually, we did a surgery compared to this. Look at this. You would end up doing a very large, right? So that's what I said. This and additional 3 millimeters, you are almost looking like a residual only 5 clock hours. Whereas this is much easier to operate. So the immune reduction thing was definitely something that was helpful.
Thank you, sir.
So can I ask a question?
7 minutes is all. Sure. No. In that case, we should probably. We can take questions anyway. I can.
So does it mean the point where the lesion is thickest, uh, the the probability of focal invasion is more there? Is there a relation like that?
That was one thing that came out as a suggestive thing, that if it's a very thick lesion. But the other downside of that was whenever you have a thick lesion, anyway your ASOCT resolution allow it. Actually, the depth of penetration and actually time domain is actually better that way. The high resolution ASOCT that Carol Karp talks about is very high resolution, shows, but the depth is even poorer than, because you're talking about 2 to 3 millimeters resolution. This has around 10 to 15 microns.
I'll ask a question. You did time domain, and this is the first time there was the studies that used to come from a lady called Carol Karp, who practices in Florida. A lot of OSSNs, and she has a high resolution ASOCT which is specially designed for that. This was the first study that came from India, and it was done on a time domain OCT. Okay. So these two studies have slightly different findings. This clear lucid zone that you see had never been reported until then. But this being the first study that came from India encouraged us to go and do ASOCT in our patients. We had spectral domain. So my question is, are there differences in the images that we obtain between time domain and spectral domain? I think you've shifted to spectral domain now.
Not really.
Okay.
Because I would have liked to, but I think we could not carry it any further because one of the things is that the anter-segment ASOCT machine, we didn't have access to a spectral domain, so an SD ASOCT. But what really added on to the information, and I think what Anashua may be able to talk about, is to bring in the component of angiography to ASOCT.
Okay.
Yeah, so that is there as technology, and she is been working on it. And the fact is that she has a very large number of patients who also have OSSN with a over an HIV positivity, which is very high.
Okay.
So that's something which is to be looked out for, but there's nothing which has come out as a publication yet.
Surya, one small thing I'll share with you is that I've been here for 15 years now. You and I, we work together, and I remember we had this protocol where for every patient with OSSN less than 40 years, we would get serology done, and they would usually be positive. 15 years, we haven't had a single HIV positive, which is
Yeah.
why I don't know. Yeah, which is what I find surprising, that why aren't the same rules applying here?
No, I
Young
think
patients.
it's the same back home. I think we should, when looking at our own experience, I wouldn't do an HIV for anybody. It's only for typically a multifocal lesion, a bilateral lesion, or a very young person. If it's somebody less than 40, I would start thinking of doing a serology. That's the experience. But she comes from a region which is very, very highly, endemic,
Okay.
and has a very high prevalence of HIV. So she's looking at that, but the angiography part. But coming to the question, the spectral domain will always have the same constraints of resolution. I mean, it is much better on the resolution, but it's on the depth.
But lower on the depth.
Yeah.
Thank you very much. This was the first class we've had in this auditorium, and you made the inaugural talk. Thank you. Okay. Thank you for the time. No. Absolutely. এটা আমি তোমাকে হ্যান্ড ওভার করে দিই। চল।
हेलो। आ, सर बोले थे वो। हेलो। Yeah, good evening. This is Shravan from Novartis. I thank you all for taking out time for this today's webinar. I'll just request to log in into the link which has been provided, because at the end of this event, certificate will go to your mail ID through which you have registered and logged in. So that is what I'll say. Keep your volume mute, because since single screen here it is projected, so all those volume and video we can access from here. সে পারলে ছবি নিয়ে
She is from Malana Azad, RP Center, and then she has done fellowship under Tarak Sharawe, Switzerland. Currently, she is executive editor for the Journal of Current Glaucoma Practice, the editor-in-chief of Clinical and Experimental Vision and Eye Research. She has more than 200 peer-reviewed publications and 17 chapters in various glaucoma textbooks. And she also does lots of social work. And one of these, founder of Vision Unlimited, a bootstrap social impact organizing the running for slum school in the Gurgaon. So basically, along with glaucoma, she does lots of social work also. Satyan, she is director of Satyan Eye Care Hospital, Coimbatore. He is a very well-known glaucoma expert, very well experienced. He was earlier the head of Eye Hospital. He has done extensive glaucoma and cataract surgery. He also was been professor in ophthalmology department. Uh, he was ex-secretary PhD Institute of Medical Science. He has been also awarded various awards, and one is Best Patient Care Project Improvement Award given by the American Academy of Ophthalmology way back in 2006. So you can see that he's quite senior. He has extensive work in glaucoma, and I'm sure that everybody will really enjoy these three people's talk and the subsequent discussion. So before I request Professor Hollow to take forward his talk, I will just give brief introduction about glaucoma. See, basically, we all know glaucoma is a chronic blinding disease, and nearly 70 million people are affected with glaucoma worldwide. Indian is more than 12 billion, so basically, nearly every fifth person to sixth person affected by glaucoma resides in India. Is one of the major cause of blindness. If you look the various population-based studies, the glaucoma detection is very poor. In some of the rural studies in India, it was found that nearly 90% of the people were unaware about the glaucoma when they were first detected. So our awareness is very poor. It is a blinding disease. 13% of population blindness is because of glaucoma. That means nearly third common. And if you remove cataract, which is treatable, is the second irreversible blinding cause of the blinding disease in the India. Of course, there are various types. If you look PACD, that covers PACS, PAC, and PACG. In Indian scenario, they more or less same. So that means the prevalence of PACG is very high in Indian subcontinent compared to the Caucasian and American population. There are various risk factors. I'm not going to go into detail about it. Age, gender, like the females have high risk of PACD, genetic history, myopia, certain race. If you look the systemic disease, systemic hypertension, sleep apnea disorders, certain medication. So these are the various the ocular and systemic risk factors. I will not cover. I will not don't want to take much time from the international speaker we have. This is EGS guideline. Of course, Professor Olo will talk in great detail. So I will skip this. Basically, glaucoma is one of the leading cause of vision-related morbidity. Early diagnosis helps because it's an irreversible disease. And I will invite Professor Holo to start his talk. And let's enjoy his talk. And then whatever questions you have, you can ask us, and we will try to answer the questions after the talks are over. Thank you. So, Professor Holo, you can start your talk, please.
Thank you very much and welcome everybody. I hope that my talk from Europe will be really useful for you in India, which is a huge country and comprises a huge number of glaucoma cases and various glaucoma types. So once again, I very much appreciate your kind invitation. So I'm going to speak about treatment paradigms and sequencing of medical treatment in open-angle glaucoma. And this is my disclaimer, obviously. What I'm going to say is my opinion, and it is not the organizer's opinion, but at the same time, it is evidence-based and is mirrored in the various editions of the European Glaucoma Society guidelines, in which I made a major role for development from the very beginning, which was almost 30 years ago. So it is very important to understand that we should not treat glaucoma patients for intraocular pressure values. The goal of glaucoma treatment is preservation of visual function adequate to the needs of the individual patient, with minimal or no side effects for the expected lifetime, without any major disruption of the patient's normal activities, and at the same time available on a sustainable cost. I have to tell you that this is not an easy task to fulfill all these criteria, and we have to make always knowledge-based but an individual decision, and this is what I try to support with my talk. So once again, our goal with glaucoma treatment and long-term management is to reduce the probability of visual disability, of developing and worsening of visual disability during the lifespan of the patient. And to that, we use as primary treatment goal low IOP, which is not just lower than the untreated, but targeted, that is target IOP. When target IOP is decided, this is an important thing because in many inadequately treated eyes, it is not decided. We have to consider several factors, what you can see on this graph. But one sector is particularly important, and this is patient preference, tolerance, adherence, and the patient's willingness of using the medication as we prescribe on the long run. If we don't reach that, the good medication will not work on the patient. It is very important to emphasize from the very beginning that my talk addresses open-angle glaucoma, which is primary open-angle glaucoma, exfoliation glaucoma, pigment dispersion glaucoma, some types of juvenile open-angle glaucoma, some ocular hypertension cases which require treatment, but I do not address angle closure glaucoma. The point is worldwide, and probably also in India, that several cases of primary angle closure glaucoma are misclassified as open-angle glaucoma and treated accordingly, which is very bad. So the main separation starts at the time of the diagnosis, and angle closure glaucomas, which require a completely different management, are not included in this particular talk. So the large randomized prospective clinical studies suggest different intraocular pressure reduction cutoff values to us for being considered an effective treatment. So we can use a 20% cutoff, a 30 or 40, but this is not what we do use in Europe. This is an American approach because according to the European Glaucoma Society on target intraocular pressure determination, we use two different approaches at the same time. One is that the pressure reduction achieved with the medication has to be at least 20% compared to the untreated baseline, preferably diurnal average value, but at the same time, it must reach 18 millimeter of mercury or lower as an absolute IOP. Why is it so? Because when we have a very high IOP at baseline and we reduce the IOP by 20%, the resulting IOP is still too high for patient. Or when we have a low IOP at the very beginning, like 19 millimeters of mercury, getting down to 18, which is just within the measurement error range, doesn't mean anything. So we need an at least 20% reduction. The target EOP, and it's also very important, is not a single value. The value we determine is the highest value in the targeted range, and this value needs to be documented in the file when we start medication. Why is it so? because many doctors think, oh, I just wanted to get down to whatever number. It's almost there, a little bit higher. Maybe it's a bit higher, but I don't care. This is not the right approach. We have to have a very clearly defined and documented upper limit of the targeted IOP range. Anything which is lower is welcome. Nothing which is higher is welcome. So if target IOP is determined, and based on visual field or structural measurements, glaucoma truly progresses, and it is not a measure of variability or just a bad imaging or poor day of the patient, but a true progression, then we have to reconsider the target value, redocument the reconsidered target value, and modify medication accordingly. Once again, individual decision making is essential. Not everybody should be considered candidates for the same cutoff values, since the damage is different, the age is different, the life expectancy is different, and there are several other factors. The most important factors are summarized in this very well-known EGS figure, which very clearly shows that individuals with advanced glaucomatous damage at the beginning, with long further life expectancy, with low untreated IOP at which the glaucoma damage developed, with additional risk factors, and particularly longer progression rates, faster progression rates, need particularly low IOP. This is not everybody, but this is the majority of the open-angle glaucoma patients, and those patients should be provided with sufficient IOP reduction and well-tolerated medications. This is the theoretical summary based on a true case of the goal of treatment. This is a patient who was followed for 5 years with visual field and imaging. This is the imaging section, retinal nerve fiber layer thickness and macular ganglion cell complex thickness. And you can see that for the 5 years time period, which comprised imaging separated with 6 months, there is a significant progression for both parameters. The decline is pretty much similar for both. But there was an intervention as indicated by the arrow, and if we consider the pre-intervention time period, which is shown on the left in the lower row, the progression is statistically significant and clinically meaningful. But when we consider the post-intervention values, they are totally flat and there is no further progression. So this is the goal of treatment. In order to achieve this treatment on the long term, we have to use topical medications that sufficiently reduce IOP to the targeted level, and not only in randomized clinical trials, but also real-life practice. Why is this distinction? Because many patients, real patients, typical patients, are excluded from the RCTs since they do not meet the inclusion criteria, but they are with us in real-life practice. In order to appropriately select the primary monotherapy, we have to see this very basic review of the classic medications, and you can see that prostaglandin derivatives provide the higher percentage IOP reduction from the untreated higher 20th IOPs. It's around 30%. Once a day medication, which is very convenient for the patient. Beta blockers provide some 25% reduction. Brimonidine, 20-25%. Topical carbonic anhydrase inhibitors alone in monotherapy do not reach the stable 20% IOP reduction. Therefore, they are not considered very practically useful medications in monotherapy. They represent a part of a complex medication. So just to summarize, all prostaglandin analog, bimatroprost, travoprost, latanoprost, and tafluprost, if available in India, they provide an approximately 30% pressure reduction with very low diurnal fluctuation. Timolol also shows a stable IOP reduction except for the night sleeping time. Brimonidine shows a large diurnal fluctuation, particularly when it is combined with something else. It's surprisingly large, the diurnal fluctuation, but it is a powerful medication. And what you do not see here, there are some newer molecules like netarsudil, not yet approved in India. It's a rho kinase inhibitor. It is pretty much similar to timolol. So if we consider the fixed combinations, the classic ones, you can see that any prostaglandin analog can be combined with timolol very successfully. Brimonidine with timolol and with a carbonic anhydrase inhibitor, which is brinzolamide. The carbonic anhydrase inhibitors can be combined with timolol and brimonidine, pilocarpine with timolol, and we have netarsudil combined with latanoprost, which I'm going to briefly report a bit later. So we have a lot to start with. But in contrast to the US, in Europe, we do not say that there are first-line medications and second-line medications. Since Europe is huge, there are many countries, poor and rich. Several countries are parts of the European Union, several other European countries are not. Therefore, we offer the available and affordable monotherapy to start with. I would not recommend a topical carbonic anhydrase inhibitor to start with as a monotherapy, but the others are fine. So as you can see on this quite complicated flowchart, when the monotherapy is introduced and the target IOP is reached, this is the left side, then we are happy and we can carefully follow the patient for IOP, visual field, and structural changes. And if the patient is stable, glaucoma does not progress, we are happy. If the first monotherapy performs as expected, but the targeted IOP range is still not yet reached, but it is a well-tolerated medication, we add a second drug, this is in the middle, and then we reevaluate whether this combined medication achieved the targeted IOP range. If yes, and this medication is available in a fixed dose combination, we switch for the fixed dose combination because of its several advantages I'm going to show you. However, if the first or the second medication is not tolerated, or the combination is still not strong enough to put down the IOP to the targeted range, we have to change either the first monotherapy or the second, or we have to go for laser or surgery. This is the basic approach. But we have to understand that this is not just a basic approach, this is a typical approach, since most patients require more than one active IOP lowering ingredient for sufficient IOP reduction. And these ingredients are really preferred in the fixed dose combinations, which increase real life efficacy and adherence. We have shown that fixed dose combinations provide similar IOP lowering efficacy compared to the corresponding unfixed installations, but they reduce the total exposure to preservatives and therefore the preservative-related ocular surface problems. They eliminate the washout effect, which very frequently happen when the patient instills from different bottles and does not wait for at least 3 minutes between the installations and washes out the first instilled medication with the second instilled medication. Altogether, fixed dose combinations reduce the total number of daily installations, which support easy life, adherence, compliance, and persistence, and therefore there is a good hope that this medication supports long-term success of glaucoma management. This is just a clinical example of my cases. Many similar cases are seen in my practice. This is a patient who was treated with several preserved topical medications, and the IOP did not move downwards, it moved upwards because of the BAK, benzalkonium chloride, toxicity from the various medications. This is the ocular surface and the cornea with infiltrates, left eye at the first visit. And then when this patient was completely washed out from the previous medications and was put on a preservative-free fixed dose combination of a prostaglandin analog and the beta blocker, the IOP went down, the patient became happy, redness, ocular surface disease disappeared. Just at 3 months from the change, this is the right eye and this is the left eye. So such things happens. The medications must be tolerated by the patients. Happy patients are much more prone to use medication as prescribed. But at the same time, medication must provide a sufficient IOP reduction. Please do not believe to any company which says to you that my medication compared to the similar class competitors reduces IOP by much higher numbers of intraocular pressure based on this and this study. All these studies for all kinds of topical medications and laser trabeculoplasties must be corrected for the untreated baseline diurnal average IOP. This is what we made for the PGA timolol fixed combinations in this particular paper, and we found that 95% of the between medication IOP reduction was explained by the different baseline IOPs. This feature is valid for the same medication. So in this study, you can see one medication which provided 31% IOP reduction when the baseline IOP was below 22 millimeter of mercury, and 40% when it was 31 millimeter of mercury or higher. So this is a general feature, and you should know what you should expect from your medication, knowing the medication performance and knowing your individual patient's IOP. At the same time, please consider that new molecules are available, and some of them are now affordable, at least in some countries, and available in fixed dose combinations. These are the new appearance of the different mono and fixed dose combinations from the EGS guidelines. You can see encircled two new players which are not yet present in India. One is the latanoprost bunod, which is a combination of latanoprost and the nitric oxide donor, which reduces IOP by increasing uvascular outflow from the latanoprost part, and a conventional outflow by the nitric oxide donor part. This is available only in the US. You also see on the low side the fixed dose combination of netarsudyl and latanoprost, which is a netarsudyl urokinase inhibitor, increases conventional outflow, and latanoprost increases uvascular outflow. So sooner or later such medications arrive to India, but you can have the others already ready for prescription for various prices, considering the different molecules, active molecules, and products. But please be aware of the uncertainty of certain medications, in particular the generic drops. Generic drops can be good and can be very bad. The general notion is that they compete with the original molecule or molecules or fixed combinations, but the real life situation is worse than that, because they also compete with each other within the generic group, and the only thing they usually offer is a cheaper price and in many cases a lower quality. So you may not be sure whether the generic medication you prescribe once one, the other month another one, perform equally well for glaucoma, whether the tolerance is the same, since the ingredients, the added ingredients, pH, osmolarity, and several other things vary a lot across the medications, and even the packaging is different. So the drop size, the ease of leaving by the drop from the drop tainer varies a lot, and patients usually do not have a major advantage of changing the different bottles and different forms of generic medications, even if they are formally, according to authorities, are alike. So when we build up a long-term IOP lowering medication, we can start with a monotherapy as I prescribed. We can add a second molecule, and when they are both effective, they provide additional IOP reduction and well tolerated. They can be combined in a fixed combination, which is great. However, this very clear approach takes more visit and a bit longer time while the final medication is set. In contrast to that, real-life practice may also start with a fixed dose combination, which theoretically offers a faster IOP reduction and a less visit and an earlier compensation of glaucoma. However, we cannot be sure whether both active ingredients of the fixed dose combination really useful for IOP lowering for the individual patient. And if any side effect appears, it remains uncertain which component of the fixed dose combination is responsible for that and which component should be replaced by another molecule or formulation. Just very briefly, beta blocker timolol is well known, 25-30% IOP reduction twice a day instillation with considerable cardiovascular and respiratory complications, low heart rate, and certain elderly individuals are not good candidates for timolol. This is what we know. When it is combined with a prostaglandin analog, same contraindications remain there, but the total amount of beta blocker exposed to the body is much less since the drop volume is smaller and only one instillation is needed. When it is combined with a carbonic anhydrase inhibitor, potential local conjunctival or local skin dermatitis, allergic dermatitis can appear due to carbonic anhydrase inhibitors, much less common than in monotherapy, since timolol blunts a lot of negative effects. When alpha mimetics are used, please note that at some patients, they reduce blood pressure, they cause dizziness because of central nervous system effects. It can reach into this central nervous system. Allergy, local allergy is not uncommon, and it remains when it is combined with beta receptor blockers and when it is combined with topical carbonic anhydrase inhibitors. But if we know this, we can play around with these medications and laser trabeculoplasty. So the conclusion is that glaucoma treatment should be for preservation of vision. IOP is just a tool for that. So when function or structure worsens, we must change medication. Set a lower IOP as target. We have to find the appropriate ways to reach the target IOP. And this is the right way to go on medium and long term, nothing else. At the same time, we have to provide good tolerance to the patients, otherwise adherence suffers. We have to know what is in the bottle. We have to be aware of the limitation between the different products. And we have to introduce the medication change early. And we should not wait for large decline of function and structure, because that is too late. Anything which is lost in glaucoma lasts forever. So we are doing a responsible job, not an easy job, and it cannot be easily automatized. This is not a routine cataract surgery. Glaucoma care remains a challenge for all of us, even in the early future. Thank you very much for your kind attention.
Thanks, Professor Hodo, for a very nice talk. You covered medical management very nicely. I'll ask Dr. Shibal. She will be talking about the challenges from the Indian perspective in medical management. Dr. Shibal, please.
Ma'am, you are on mute, I think. Can't. Tech, can you help her with the voice? Yeah.
Is that okay? And I'm sharing the wrong screen, I believe.
Yes.
Just give me a minute, please. I can't seem to share my screen. Can you hear me now, please?
Yes, we can hear you. Your screen.
I am on the WebEx screen. I'm unable to share my. Can you see my screen now?
Yes, ma'am.
Okay. So thank you so much, and I'm sorry about that glitch. It is never easy to do this, despite having tried on in a pre-meeting schedule. It's a privilege also to walk you through the unique changes and challenges that confront the glaucoma practitioner in India. We are now the most populous country in the world, with a rampant income disparity and disproportionate access to healthcare. And to hear Professor Hollow speak about similar disproportionate access to healthcare and income disparity over Europe was such a welcome change from how we look at practice in India. Before we delve into the Indian problem, I will just walk you through my disclaimer. Just give me a minute. Right, the views and opinions are mine. All of them are based in evidence-based medicine, which, of course, the organizers of the seminar do not take responsibility for what I'm going to speak. Before we delve into the Indian problem, just a quick recap of the unique clinical spectrum that is glaucoma. We've been taught that the quality of life drops in glaucoma when the disease progresses to advanced field loss. However, our clinical experience has been contrary to conventional wisdom. The diagnosis of glaucoma itself is a serious quality of life cost, as is glaucoma treatment. Glaucoma is an asymptomatic disease only until we start glaucoma therapy. Attendant problems, therefore, in the Indian context as the rest of the world include underdiagnosis, overdiagnosis, choosing the appropriate therapy, and of course, patient compliance. The main challenges, therefore, as for anywhere else, and Professor Hollow walked us through them for Europe, the proper diagnosis and setting the target IOP, choosing the right therapy, because there are so many empirical elements that have to be kept in mind when we decide to choose glaucoma therapy. Compliance and adherence, identifying the non-responders and those who have poor compliance and differentiating between the two, and in case of progression despite IOP control, identification and management of factors beyond intraocular pressure. As for prescribing patterns in India, as of last year, the study from PGI Chandigarh showed that the most common therapy in India, the most common monotherapy in India was timolol. This was followed by travoprost and brimonidine. Most patients who were from the center itself were on an average of 2 drugs, while those which had been referred for a second opinion to PGI Chandigarh were on 5 drugs. 70% of patients in this particular study were on combination therapy. Carbonic anhydrase inhibitors, about 30% patients, and only 20% of patients that this group studied were actually on prostaglandin analogs. 40% of the patients were on FDCs, fixed drug combinations, and the most common FDC was brimonidine with timolol. An older study from Central India said that the average number of medications in their patient subgroup was 1.36. Once again, beta blockers ruled, timolol almost 60% of patients. The least common in this group also was prostaglandin analogs, with only 5% of the patients receiving PGAs, and again, 41% were on fixed dose combinations. Most studies on compliance in the country, just like the rest of the world, peg it at 50%, with factors ranging from cost to ease of access to patients forgetting to use the eye drops, of course, side effects and schedule complexity. The Indian glaucoma patient is not very different from the rest of the world. It is, however, important to note that unlike most patients in Europe and in the United States, insurance in India doesn't cover glaucoma medications or outpatient procedures, and glaucoma medications are dispensed free of cost in selected public hospitals, and the most commonly available AGM in most centers which are dispensing free medication is timolol, and hence the popularity of the drug in the country. When we look at identifying the antecedents of adherence, adjunctive therapy involving multiple medication bottles adds not just complexity in comparison to a single agent monotherapy. As Dr. Hollow pointed out, it also means more visits of the patients and may also introduce a washout effect if the co-administered drops are not spaced adequately in time. Non-adherence has been related to patients receiving multiple medications. Adherence amongst glaucoma patients decreased from 81% when they were on one medication to 50% when they were on 4 medications. And similarly, there was a 20% increase in adherence when the patient was shifted to an FDC as compared to concomitant medications, compared with concomitant administration of the 2 separate medications. Now, what we have to understand is better adherence requires both the doctor and the patient to be happy. So the key strategies to improve compliance, therefore, are to choose something which has better 24-hour and long-term efficacy, something that decreases the medication number and schedule complexity, limits preservative exposure and therefore improves patient comfort, improve communications, especially the biggest game changer apparently is teaching the patient how to use eye drops. FDCs, therefore, are key to improving adherence. And of the FDCs that are available globally, we have access to almost all of them except the combination of nitarsodil with latanoprost and tafilprost with timolol. The only beta blocker free FDC that we have is brimonidine with brinzolamide that is available to us. The non-PGA FDCs include timolol with dorzolamide, brimonidine, and brinzolamide. Dr. Hollow has very elegantly covered the unique position of prostaglandins as the first line, what is not really called the first line, but one of the frontliners in the treatment of glaucoma, and its combination with the timolol and his talk on sequencing paradigm. So I will be focusing on the non-prostaglandin FDCs. So the first of which that we will talk about is the brinzolamide with timolol fixed drug combination. This is a very interesting real-world experience of BTFC with more than... Just give me a minute, please. I think I have got this in fixed dose combination. Better IOP control than previous therapies. The FDC actually demonstrated favorably in 87% of patients versus 53% of patients, including tolerability and a high satisfaction rating of 93.4%. A strong patient preference for brinzolamide timolol was noted over previous therapies. 82% preferred the brinzolamide timolol combination as compared to dorzolamide timolol, and 76% preferred BTFC when compared to brimonidine and timolol. A word of caution when interpreting these numbers: all of these patients were retrospectively analyzed and they had been shifted to another combination, basically because they had been unhappy with what they were initially. So it only goes to show that when we do shift patients, we do expect change, and so many of them do become more comfortable with the brinzolamide timolol combination. Both brimonidine and brinzolamide plus timolol decrease the mean and 24-hour IOP at each time. Brinzolamide and timolol, understandably, has better mean 24-hour control owing to greater efficacy in the late afternoon and during the night. That's again something that we've known about the molecules initially. Similarly, brinzolamide with timolol was found to be non-inferior to dorzolamide plus timolol in IOP reduction when added to prostaglandin-treated patients. So this can be considered a safe and effective adjunct to prostaglandin analogues for patients who require more than just the one drug. And now coming to the BBFC, the beta blocker free brimonidine plus brinzolamide FDC. Brinzolamide plus brimonidine have shown significant superior 24-hour IOP lowering efficacy when compared to a vehicle, but that's understandable again. And at all 4 time points in this particular study, the beta blocker fixed combination group demonstrated the largest percentage reduction in IOP from baseline as compared to brimonidine or brinzolamide alone, and the mean IOP of the BBFC group was significantly lower. Again, evaluating the beta blocker fixed combination as an adjunct to just move on to the next one. Teprusis et al. Found that the mean change in IOP, diurnal IOP from baseline at week 6 was greater with the BBFC plus PGA group, almost 3.5 millimeters of mercury. The safety findings were consistent with the known safety profile of the individual medication. In this particular study, where Musavi et al. Changed patients who had been switched for any reason, just like the big study we discussed earlier, the mean change in IOP after the introduction of BBFC was 2.75 millimeters of mercury, and there was a small reduction in the number of bottles of IOP-lowering medication per eye. Now, the most important thing to remember is that the drops don't work if the patients don't use them, and the high early dropout ratio is known to happen in glaucoma, irrespective of drug use. This can be attributed to both the disease itself and the treatment characteristics. However, increased persistence with FDC is known as compared to separate bottles. Potential of benefits of FDCs, therefore, are game changers when it comes to compliance and adherence in patients who need multiple medicines, especially as Professor Hollows spoke of it, that prostaglandin analogs may not be the first choice. And as we've seen in our own prescription patterns from our country, that we are not choosing to use prostaglandin analogs as much as we would have thought we were using them. The potential benefits, of course, are enhanced convenience, improved adherence, a decreased exposure to preservatives, possible cost savings, reduction in medication complexity, and minimized washout. Once again, a word of caution for when you're using generics. If a patient is being controlled on an innovator molecule, please make sure you relook at their intraocular pressure faster. If you see any decrease, see if you can shift them back to the innovator molecule. And if you see an increased incidence of side effects with generics, it's always good to contact the people who are making these to let them know that this is what has happened. And as the Prof mentioned, the goals for glaucoma specialists are universal and not just limited to the Indian context. We are all working to preserve the quality of life of the patients, preserve the functional vision with minimal side effects, keeping the economics of glaucoma in mind, along with disability and quality adjusted life years. As far as visual function is concerned, we are of course trying to preserve the visual field with the ultimate goal of prevention of blindness. The target IOP must keep in consideration the risks and benefits of glaucoma therapy, and the cost of the treatment is not just the cost of medication, but also the quality of life, of course, that the patient pays for each additional bottle, and our treatment must be customized to each patient. And to summarize, in India, more than half our patients are non-compliant with glaucoma medication. More than 1/3 of our patients require more than one medication at the onset to control the disease. Fixed dose combinations are important adjuncts to the armamentarium of available glaucoma therapies. And just as the Prof said, it is just so important to remember that the science of glaucoma is incomplete unless we bring compassion to the table, which is how clinical outcomes are determined. Thank you so much for having me here. It has been a pleasure to do this. I have to try and stop sharing my screen and I'm unable to do it. Can I have some support, please?
Can anyone help Dr. Shibal?
Yeah, I think I've stopped sharing.
Yeah,
Is that?
yeah, good. Yeah,
Thank
thanks
you so
Dr.
much.
Shibal for a nice talk. So basically the non-adherence, I think in Indian subcontinent is more or less similar as the other part of the world. So unequally developed countries, I think the adherence remains more or less same. So that's a good thing. So before we go into discussion, I'll ask Dr. Satyam to share his talk. He will talk about a few interesting cases. Satyam, please go ahead.
Yeah. Thanks, Rajul, and welcome everybody for this wonderful glaucoma event today. And it is as difficult as treating glaucoma. Covering two topics in 10 minutes is quite difficult. This is my disclaimer. And I'll just share this first case. You can see this patient has come in the year 2013. He is a 50 years old gentleman, and he presented with the normal anterior segment with the 21 and 22 IOP with the open angles. And you can see that in the right eye he has an inferior notch with the wedge defect, and also in the left eye you can see both superior and the inferior RNFL loss. So in the year 2013, we have started the patient on bimetoprost. For some reason, the bimetoprost wasn't available, so patient was shifted to travoprost. And the IOP was maintained on 15 and 16. We know that the normal, even the normal people will have the visual decay. But in glaucoma, if you are treating, probably around 0.4 to 0.6 can have the visual decay. That is a decibels per year. But looking at this patient, you can see this patient was considered to be within the mild to moderate glaucoma with the both in the right eye and as well as in the left eye. The patient was on treatment without much of a change. But then, so we know that the progression can have a significant effect on the patient's quality of life. The patient with the age of 50 years, if the patient is in the D group, then it is fine. But once the patient is not in the D group, and if he goes in the E here, then he can have a significant visual loss. So we know that from the previous speakers that setting the target pressure is extremely important, but then there are two criteria. One is the amount of damage what the patient has and the amount of IOP, untreated IOP. These two things play a major role. Looking at this patient, the early to moderate glaucoma, the IOP of around 15-16 is reasonably okay for this patient. So he was on medication. Looking at the PGA, we know that it has the highest systemic safety and could reach the target IOP, and it can maintain the IOP for about 24 hours. And it is one-sided dosing, which is very convenient. So all this was happening till 2016. But let's see what has happened in the year 2019. Look at the IOP it is about 16 millimeters of mercury, but then you can see the change from 16 to 19. There is a significant change has happened. There's a significant progression. So he has jumped into both eyes, right as well as in the left. You can see that he has gone in for a moderate to severe disease. So from the previous studies like EMGT or UKGTS studies, all these studies have shown that about even if you have treated the patient under control, still they can have the progression of about 20 to 25% reduction. Still the IOP, the progression can happen in 14 to 15% of the patients. So once you see that the progression, what you need to understand is we need to go for the further IOP reduction, even if you feel sorry about that. So we have to consider much lower target intraocular pressures. So now you can see here what has happened after treatment with the second or third line of drugs. We can see from 2019 to 2023, there is not much of a progression, both in the right as well as in the left. Not only it is shown in the visual fields, but if you see the OCT also, there is not much of a progression in both eyes. Now the IOP is 11 and 12 with the same open angles, but the patient is on combination of travatan with the timolol and also separately the dorzolamide. But it is not adequate for you to understand. It is just not adequate if you just treat only with the IOP. But this patient also had the sleep apnea. We know that very well sleep apnea also causes the progression of the disease. So we need to understand failed monotherapy. We have to understand other factors also we need to take care. But again, controlling the intraocular pressure with the other group of medications also as essential as, like controlling the disease. So sleep apnea also needs to be taken care. So understanding the risk profile of the patient when we start planning for the disease is extremely important. Understanding the target pressure, the main two factors play is one is the visual fields and the intraocular pressure. but we have to keep on looking for what kind of a change the patient has over a period of time. And if we can really pick up that as early as possible, and if we can treat the patients with either the additional one more drug, or if we can go for the combinations, like most effective combination being the PG and timolol, and of course other needs to be added over a period of time. So this really helps the patients to have a good quality of life and the patient being under control with the disease. So this is the fixed monotherapy, the monotherapy failed, what happens? So we'll just look into the next one. So this is basically on the compliance concerns in a patient with multiple IOP lowering eye drops. So this is a patient who is already on treatment for carcinoma with the secondaries, but unfortunately I also have to put the patient on multiple drugs, like the patient is on 6 different medications. For the right eye separate medications, for the left eye separate medications, and of course the patient had other complications in the eye because of the topical anti-glaucoma medications. It is not very uncommon for us to see this kind of complications where the patient develops the side effects for the multiple drugs. So compliance to glaucoma medications is, as Rajul was mentioning, whether it is a developed country or developing country, educated, uneducated, urban or rural, everybody has the same problem of compliance. There are many reasons could be there, but the disease as such, the disease has no provocative symptoms, all of us know that, and also of course the lack of awareness and knowledge about the condition is another main factors. So looking at the concepts, what is the real compliance means? It is an extent to which a patient takes a prescribed medication is the compliance. Then there are other two words which we need to remember is one is the adherence. It is to an extent which the patient self-administers the prescribed medication exactly as prescribed is adherence. Persistence is how long the patient is able to continue with the prescription. So there's the 3 things which we need to remember. So why do the people go blind in spite of the treatment in glaucoma is most likely the cause is the non-compliance. Most patients miss some drops, some patients miss most drops, and few miss almost all drops. So is it really possible for us to easily identify who is having the non-compliance and omitted doses? It is not that easy unless the patient is very truthful. Many times we have seen that the patient coming to the clinic with a good control of IOP, but they might have just used the drops previous night or the day of the checkup. So we need to understand, you can look at here, this is one of the studies from developed countries shows that 97% of the patients are compliant as per their self-report. But unfortunately, the true thing showed is about only 76% from the microchip. So the issues of non-compliance could be because of the multiple medications, multiple daily dosing requirements, side effects of the medications like what our patients had. So the patient's misconceptions of the disease caused inadequate counseling, but the number is just not ending here. The problems, many patients will have their own way of looking at things. So if you are just given one medications, probably the compliance may be better than when you are giving it for the multiple medications. You can see here it significantly drops down. But is that okay to give once daily dosing and you can expect a good compliance? But in contrast, what has happened is the majority physician thinks yes, but unfortunately the patient thinks in the other way around. It is only 20% of them they accepted that once a day also and can improve the compliance. So the problems with the multiple medications could be because the drops, administration, difficulty in paying, the side effects, and the trouble remembering, all those things. So this is not only that compliance to apply the medications. This is one of our published articles, studies. It is for the follow-up also the patient fails to come for the follow. The reasons are the lack of awareness or knowledge. And you can see the physical reasons, incidental reasons, inconvenience, financials. But we need to just understand the patient a little bit holistically. We think that once we say whatever we say, the patient will remember everything or understands everything. It is not the way. What we say 10 times, probably the patient may understand only once what we are saying. So categorization of the interventions may have to be like a behavioral, educational, or affective. But there are many different ways we need to go for how best we can make the patients understand and apply the medications. So you have to understand the patient better to make them, how best we can maintain their quality of vision throughout their lifetime. That's what our goal is going to be. So thank you so much. I think I've just rushed through a little faster, but the time given is only 10 minutes. So I think I've reasonably done the justice to the topic.
Yeah, thanks, Dr. Satyan. Very, very nicely you covered. Adherence is a big issue and big headache to all the people who treat glaucoma. You try to cover very nicely. And we also remember
one why I just presented this particular patient is though the patient is compliant to the drugs because of the side effects, still the patient is continuing, but the disease is still progressing. It is not just enough to think about the compliance, but there are other many factors which we need to consider when we are treating the disease.
that systemic disease and everything also will cover. But adherence also is a big issue because especially in early glaucoma where patients do not have any symptom, the drugs are going to cause side effect, some or other. So from patient perspective, we have given him the problem which he or she never had. So we have to be very cautious and explaining the patient about the disease, long-term effect. And as you mentioned, they forget. So we have to keep reiterating. The chair time is very important in glaucoma management. So if we, in the follow-up visit, we don't give proper chair time, the patient's adherence is going to only decrease. Professor Holo, you want to give any comment about the adherence or what in your practice you do and how you make sure patient follow the advice properly?
Thank you very much for the question. I have to tell you that almost for 40 years, I was doing the glaucoma unit of the Semmelweis University in Budapest, which is the main medical university in Hungary. Those patients I saw there, they were the problem cases, and most of them, almost all, really appreciated clear and detailed advice on their stage of the disease, tasks, and understanding as an active participant in the management of their own diseases. So this is what I was doing. What I'm doing now is quite, let's say, privileged practice. It's not a cheap practice, so this makes a strong selection for the patients, and those who come, they even more appreciate the clear education. But what I have to tell you, even in these patients who devote time, pay money, work hard for years or decades on their own disease, misunderstanding of their disease, lack of understanding of the tasks he or she needs to do is very common. So a major role of glaucoma specialists and eye doctors in general is to clearly explain the patient, very simply but clearly, what is the disease he or she is about, what is the expected consequence, what is the expected consequence for the close family members, for the blood relatives, because that is a strong stimulation for patients and the relatives. When they see what happened to my mom or my grandfather, I don't want to get the same. So they are much more prone to accept clear and manageable medical directions. And finally, but most importantly, the tasks which need to be done by the patient should be clear, simple, and should very much consider the normal life routine of the individual patients. Those who live in the night should not be instructed to use medications in the night. Those who are, at least in my country it happens, start the day very early in agriculture should not be instructed to start to use medication early on. They will never do that. They run to the field, and when somebody is not really capable to self-administer topical medication, we have to explain how to get a once a day support from a neighbor, a close family member or a supporting nurse provided by the system, which can simply substitute the suffer of the patient's own self-installation, which is usually insufficient in advanced glaucoma.
Nice explanation. Basically, we have to individualize the treatment depending upon the patient's day-to-day activity. So otherwise, the treatment, because patient is not going to follow. Shibal, Satyan, anything you want to add about from the Indian perspective? Because the Indian still we have the support system is much better than the Caucasian because of the joint family. But anything you want to add, Satyan?
Rajul, I just wanted to share two different areas where I worked. For 20 years, I was at Arvind Eye Hospital where we were seeing about 250 to 300 patients, and we had a huge data. When we collected the data for about 11 years or 12 years, when you really look at their follow-up rate, it is only 9% at the end of 11th year. Whether it is a surgical patient or whether the patient is on medication, both the groups significantly had a lower follow-up rate. So I was just thinking, when you go for a separate private practice, you think that your patients follow up in spite of you spending more chat time, you might think that your patients follow up is better. But truly speaking, in these last 11 years or 12 years in my private practice, the amount of follow-up seems to be almost the same. It is not only the understanding or education which you give, it is the patient attitude and various other factors also significantly contribute to the follow-up. We might be thinking that all our patients are coming back for follow-up, but it is not the truth. It is only our feeling that the patients are coming back for follow-up. But when you really look at the data sets, then it doesn't give you the same. It could have been patients say that they are no more or they are visiting somewhere. All these things, even if you eliminate, the percentage of follow-up is still almost like 10%, 11% at the end of 10th year or 12th year. That's very scary, but then that is the reality that we are facing.
I think that also depends upon the education and the area where you are practicing. Because I think metro, I'm not feeling. I mean, I don't go by feeling. So I think in my practice, the follow up is much better than 10%. My and Shefari's practice, that I can tell you, it's the data. Of course, there are lots of factors as you mentioned.
There are many factors. The age, if you really look at the age, the younger ones, we think they're becoming for a better follow.
And the professor Holo was talking about the relative having glaucoma. Sometimes it doesn't work. I've seen patients, they're having their own parent, father or mother.
individual patient. What I have seen in my practice, and this also holds true for others and all yours as well, I'm sure, where the patient starts off very, very pronto, very almost scared of the fact that they have glaucoma, and they're very, very compliant initially. But as time goes by, one, side effects start, and two, they also see that nothing's going wrong. Like, they've been 3 years with you, and year 4, they're like, Sab theek hai, it's all been the same as before. My vision is still 100%, and that is a limiting factor.
Other side, if they don't have any problem, then they feel that.
Yes, so why am I these eye drops? So many patients who come back saying, I stopped the eye drop, nothing's gone wrong. I mean, I've been using it for 4 years. It didn't help. And it hasn't, I'm not using it for a couple of years, hasn't changed anything. And then you look at all these black spotches on their visual field, and that's a different story. But the patient doesn't feel any different more often than not.
It is right. It is right. Okay.
So Rajul, I'll actually go with Sibyl. It is not the cost. Many of our patients, they don't say about the cost. Maybe sometimes they may hide it.
Not many, but
Most of the time it is the attitude of the patient over a period of time what happens. If you really typically see after the third or fourth bottle, that is like 4 to 6 months time, that is exactly where the decline of the compliance starts beginning. So that's what I have typically seen in majority of our group of patients.
I'm sorry.
First few months they are very, very compliant, and then slowly they start moving away as they don't see any trouble for their eyes.
Okay. So so there is one question that which classification do you use for the glaucoma? So I think if you just read the EGS guideline. If you look the Glaucoma Society of India guideline, the classification is mentioned very nicely. We are not going to talk about it. Professor Horo, there is one question.
More pigmented, and therefore SLT, even low dose SLT, is a good way to reduce IOP in open-angle glaucomas. But what I should like to say that I started early, but I always start at least from the time of the laser treatment or even from earlier with some topical medication, because SLT will use IOP after 1 to 3 months, and this temporary time period should be somehow covered with topical medication. Maybe topical medication is just dropped later on and the patient is followed without any topical medication, or it works as an add-on with a laser. but SLT is not expected to sufficiently reduce IOP immediately after the medication. So the few weeks or 1 or 2 months needs to be covered with topical medication.
And you do treat only early glaucoma, or
No, not at all. Not at all. The first visit cases are usually not early glaucoma cases, but moderate to advanced glaucoma cases with a treatment history, but not with SLT in the treatment history. That's very typical for my country. So I usually reorganize topical medication because that's usually not good. And it's quite obvious. And then I add on or introduce laser treatment, selective laser trabeculoplasty as a part of the new treatment. And the patient has to come back after some weeks, once again, until the IOP is finally at the achieved value, and then I can make a judgment whether I'm happy with that or not. And during these visits, additional visual fields, additional OCTs, additional OCT angiography measurements are made. So it's very early to present the patient whether there is a decline, a progression, or everything is stable, and the patients really appreciate being involved in these parts of scientific and very medical aspects of their own treatment.
Okay. So we have a couple of questions and then we'll finish. The professor, one question: how you identify target IOP achieved in your patient?
Target IOP with a tube. Was this a question?
Yeah, how to identify target IOP is achieved. So basically, how do you set target IOP? And how you follow up the patient?
Sure. The general approach is that early glaucoma requires a bit less low target IOP, which is easier to achieve and more advanced more. But first of all, when the patient arrives, and these are typically chronically treated patients with significant progression in the previous treatment time period without any, let's say, modern management. So if it is not an end-stage glaucoma, just a moderate glaucoma or a moderate to advanced glaucoma, I completely wash out the patient from the existing medication for 2 to 3 weeks. I go for a daytime phasing, and then in general, I address an at least 30% IOP reduction compared to that if it is between 20 and 25 or 25 to less than 30. In other cases, in advanced cases, of course, I go for lower. So let's say for untreated, completely washed out patients whose daytime IOP is approximately 25 millimeter of mercury, moderate visual field damage, I would go as a target for around 15 millimeter of mercury IOP, which is quite possible by combining 2 fixed dose combination in my country. And if I want, I add a selective laser treatment.
Okay, thanks. So the last question, Shibal and Satyan, the guideline EGS and more or less most of the guideline that we should do at least 5 to 6 field in first 2 years, the first time. Do you follow? And how frequently you would like to do the perimetry? There is a question: how frequently you would like to do perimetry? I just added the other part.
I'll pass this difficult question to Sibal.
So ideally 3 to 4 fields a year, if we can do it. The early glaucomas, I call them back after usually 6 months to a year. The more advanced glaucomas, yes, I would like to adhere to these guidelines, because in the earlier stages, to have a patient come back every 3 months is a serious economic cost, and a serious cost in terms of time, because invariably the first field is rejected because the patient is still learning to use the machine. You call them back for a second field, maybe a third, to get a baseline that's reliable, and thereafter maybe a 6 monthly is what I can push for, no more than that. In the advanced cases, yes, I do ask for 3 fields to 4 in a year.
Yeah, Rajul, why I said it is such a difficult question is, though we know the guidelines, But many times in reality, we may not be able to really
I
achieve
totally
that,
agree.
especially when the patient has to pay for each and everything. And then
Exactly.
with so much of other issues, it's really difficult to
Anyway,
get
and
it done in our own
keeping the
context.
advanced glaucoma patient on perimetry, that also is a big task,
Yeah.
because what they feel that anyway they can't see. So what is the objective? So, but as you mentioned, I don't do 3 monthly advanced glaucoma. I do 6 to 6. Once I know, I do 4 or 5 fits in first 2 years. Once I know patient is slow progressor, then I early glaucoma definitely once a year. Advanced glaucoma 4 to 6 months, not every 3 months, 6 monthly.
That's a tough one to pull. I mean, if you
Yeah.
can get a patient who will come to you every 3 months, I mean, you're doing something right.
So, yeah, Professor Rola,
It really has to be really individualized. Sometimes
yes,
we'll have to
every
manage
person.
even without fields, OCT, everything. We'll still have to manage it by looking at the disc. So there are a lot of other things happening.
Guidelines are more like general directions, like go towards the north or go towards the west. But where you have to reach is so individual that you have to take this right turn
Every
from
patient
this.
is different. Yes.
Yeah, every patient is different and every patient is a challenge unique to themselves.
Yeah, but ultimately what we need is how much we can really control the disease so that he can see throughout his lifetime.
Agreed. Professor, you want to add any concluding remarks, and then we finish this session? We are already overshot by 6-7 minutes. So just your final comments. In fact, all three can give one final comment, and then we end. Professor, we start with you.
Thank you. I really enjoyed being with you. More or less similar problems seem to influence glaucoma management in India and in Hungary. Just one more word. So I generally go for 6 visual fields per year in the first, 3 visual fields per 3 visual fields per year for the first 2 years. And then when a patient is really stable, I just go for once a year or so. But I also very much use in early glaucoma OCT. I use a high quality system, and OCT progression analysis for early glaucoma is much better than visual field testing, much better for the patient, much more convenient for the patient, and the diagnostic power to detect worsening in early glaucoma is better for OCT. So that's all. Otherwise, I was very happy to see that we are basically more or less on the same level, on the same problems. So I do hope that the solutions, what will be gradually worked out in the world, will reach each of the countries we all represent. Thank you very much for your kind invitation once again.
Satyan, Shibal, anything before we conclude?
One thing is we may like so many things the patient, we want them to follow, but understanding the patient holistically makes a lot of sense in treating the glaucoma. Thank you.
And it really helps if you believe in God, because treating glaucoma needs a lot of assistance from someone not knowing, because there's just so little that you can control. And think of a patient as yourself, because I am a horrible patient myself. I am sitting through this with a terrible migraine because I forgot my Razact in the afternoon. But that's how life is, and no patient is different from you and me. And once we keep that in mind, then making choices on their behalf perhaps becomes a little easier. Thank you so much for having me. It's a privilege to be with Satyan and the Prof, and of course Rajul's here as well. Thank you so much.
It was a nice presentation, Professor, follow-up, Satyan, Shibal. Really enjoyed the session. I'm sure our delegates also must have enjoyed. I'll hand over to Snehaprabha for a word of thanks before we conclude the session. Snehaprabha, please.
Just a small thanks from my side to the entire tech team and the Novartis team and the Insignia team. Thank you so much.
Thank you. Thank you so much. It was indeed a wonderful session. And I would like to thank all the faculties, Dr. Parikh, Dr. Hollow, Dr. Shibal, and Dr. Satyan for their valuable time. And the session has really helped to understand the barrier challenges in glaucoma management and the various options which are available, and to overcome them and appropriately manage glaucoma in Indian population and to preserve the vision. So I would also like to thank Novartis for sponsoring this educational initiative. I would like to thank the participants and request them to fill the feedback form. And yes, thank you. It was indeed a great session, and a happy weekend over here. And good night.
Thank you
Thank
and
you.
good night.
Thank you.
Good night.
Rashida. Yes.
Goodbye. Bye bye.